So hello and welcome back. I'll be starting off on the discussion of the functioning of the immune system, and part one will be fundamental immune mechanisms with a functional overview of how the intact immune system meanwhile functions. That is, we'll try to understand the three basic immunological circuits, as I like to call them. We'll iterate the differences between the innate and adaptive immune system and or responses rather. Then we'll understand the constraints that have governed the evolution of our immune systems, and we'll enumerate the topics that I'll be covering subsequently in this discussion. We'll describe how the fact that the innate immune system and the adaptive immune system have evolved results in significant functional redundancy, and how that affects how we study the immune system and what difficulties it arise because of that. And finally, we'll discuss why all of this matters to us as clinicians who are interested in diagnosing individual patients. It's surprisingly relevant, as we'll come to know subsequently. Okay, so the most basic immune circuit is as follows. So, say a pathogen attempts an entry into a human being. That results in the pathogen giving a pathogen specific stimulus. So, this could be a bacteria, this could be a virus, this could be a parasite. They have particular molecular signatures on their surfaces that are known or that have been exposed or yeah, that are recognized by the innate immune system. So as a result of that, what ends up happening is that the stimulus is detected by your immune system. That results in processing of that stimulus, and that processing eventually results in a valid response developing. And that response then attempts to inhibit the entry of the pathogen, either by killing the pathogen or by doing something else. So this is the most basic, circuit that you can be drawn within the immune system. And essentially, the detection, processing, and response, all of those can happen within one single cell. So if it happens within one single cell, for example, if I was to replace this with a macrophage, say a macrophage, this would be the most basic immune response that exists. And this is there actually is evolutionarily conserved in even non-chordate organisms. So uh, this is the most basic mechanism, and this is fairly simple. Now here we don't have to talk about cell-cell interactions. However, this can also happen when the responses are outside of cells. That is, there is no cell involved, and this is happening purely within the serum or within the blood. So that an example of that is when the complement system detects a certain pathogen and then creates a response, and we'll be talking about the complement system subsequently. So this is the most basic circuit, very simple thing, nothing very complicated. Now, taking it up a notch, we'll talk about a more complex, but again, still purely innate. So it consists of cells that are traditionally called innate cells. For example, this macrophage that I've drawn on one side. So the response remains the same. So an attempted pathogen entry happens, which results in a pathogen-specific stimulus being exposed to the immune system being exposed to a pathogen-specific stimulus, detection of that stimulus, processing of the that information, and an appropriate response being arrived upon by the immune system. So now this same process can happen when there are two cells involved. So there's a separate cell for detection and processing, and there is a separate cell for response. And therefore, naturally, these two cells will have to interact with each other, and therefore, we'll have to have a whole slew of proteins or mediators that allow for this kind of a cell-to-cell signaling to occur. So, just as an example, I could replace the first cell with our macrophage, or indeed, I could replace it even with another cell known as a dendritic cell. And a response could be due to whether this is a neutrophil. We know that because there are three lobes to the nuclei, and there are reddish or eosinophilic granules within the cytoplasm. So this is again a very simple circuit, but there are two cells involved, and there is cell to cell signaling involved. And both cells are essentially part of the innate immune system. And we'll discuss just now what that means. Now, an example of this detection and processing cell could be a macrophage or a dendritic cell. For those of you who are completely uninitiated, these are the two cells that are classically, described as being able to detect pathogens. Although essentially any nucleated cell can do that. However, these are much more primed to do it. And then we have some effector cells that go and kill the pathogen. That could be neutrophil. It could also be again a eosinophil, and this is what an eosinophil looks like. It has a bilobe nucleus and orange granules within cytoplasm. And again, it could be macrophage. Okay, so again, relatively simple circuit. Essentially, the only difference is that there are two cells instead of one cell, and therefore those two cells have to interact with one another. Now, coming to the most advanced circuits that we have, that is the adaptive immune circuits. So here again, the pathogen attempts a entry into the human host, and that results in a pathogen specific stimulus being generated, some molecular pattern on the pathogen that gets detected by the immune system. That results in again a processing of that information. Now this part is exactly the same as I just discussed, resulting in a response and a response that tries to inhibit the pathogen's entry and or tries to kill the pathogen. Okay. Now, however, it is not successful, as in the innate immune system is not able to adequately control the pathogen, and that results in a highly specific further processing happening of the stimulus that is being provided by the pathogen. Now, that in turn results in highly specific immune responses occurring, and those highly specific immune responses further inhibit the pathogen. Now, the important thing here is the high specificity. Okay, so again, right off the bat, you can tell that the main difference between the innate and adaptive immune responses is the degree of specificity to the pathogen. Now, again, the detection in the first step could be due to a macrophage or a dendritic cell. Similarly, the response in the first stage again would be due to a neutrophil or say an eosinophil or a macrophage. So I'll replace that there. Now, till here, the responses are essentially the same. Okay, but as you can see, the adaptive immune responses occur above and over the innate immune responses. So now what ends up happening is highly specific processing occurs within a cell known as a lymphocyte. Okay, and specifically, this is a T lymphocyte. So the pathogen is processed by the macrophage and then presented to the T lymphocyte, or alternatively, the pathogen's specific molecular patterns are detected directly by another cell known as a B lymphocyte. So that highly specific processing would be occurring in a B lymphocyte. Okay, so this would be a B lymphocyte. So now what ends up happening is this is the actual circuit. That is via the macrophage or dendritic cell, a T cell gets activated, directly a B cell gets activated, and the T cell agrees with the B cell that this is the pathogen that we've detected and this is the response that we have to develop. So there is a cell to cell interaction occurring here, and the processing is actually at a cellular level. That is intracellular interactions determine the processing, adding another layer of specificity. Then a B lymphocyte produces a highly specific response. Now, some T lymphocytes like CD8 plus T cell lymphocytes can directly, be interact with macrophages and then produce a highly specific response. But I'm trying to simplify things here. So this is a CD4 plus T cell. That is a helper T cell in normal parlance, and that is helping your B for lymphocyte produce a highly specific immune response, and this highly specific immune response is basically a protein called an antibody. So that is an antibody. Okay, so again, the circuit is not particularly complicated. There is a basic similarity to the second circuit that we discussed, but on top of that, because the initial innate immune response was unable to control the influx of the pathogen, that resulted in subsequent activation of T cells, specifically helper T cells, and direct activation of B lymphocytes, resulting in antibody production. So this is actually for anybody who has learned the immune response at any level. This is a very basic thing, but for the uninitiated, and because I'm going to be discussing the actual dynamics of all of this in vivo and how that affects our clinical interpretation of things, it's important to reiterate. Okay, now coming to the differences between the innate and adaptive immune systems. We have the innate immune system, we have the adaptive immune system. Now, the first thing that is the first difference is the difference in the mechanism of detection of pathogen. that is stimulus recognition. So the innate immune system expresses a slew of multiple receptors that are germline encoded. That is, every single human being has got the same receptor, uh, essentially the same receptor with very little variation, and especially every cell in that same human being has got the same receptor exactly. Okay, so within a person, the receptor is exactly the same in all cells. So there is a degree of such, structural invariancy, or the structure is very relatively constant across all cells. Whereas the adaptive immune system detects the pathogen using receptors that undergo a process known as somatic hypermutation. Okay, somatic implying that it is not happening in germ cells before the zygote is formed during development. It is occurring later. Okay, and hypermutation is it is occurring at a rate much higher than the normal mutation rates that occur in cells. So we'll get into the details of this in subsequent videos in this series. And this process through natural selection actually results in increased potency for binding of these receptors to the pathogen itself. And therefore, the interaction between the adaptive immune system and the pathogen becomes progressively more specific. Okay. Now, processing in the innate immune system may be restricted to one cell, that is the simplest circuit that we saw, or it may involve multiple cells that communicate with one another. But usually, this is restricted to maximum two cells, maybe three. Okay, beyond that, it doesn't go. Whereas in the adaptive immune system, interactions go through multiple cell types, and actually very strong, to and fro interactions have to occur between specific T cells and B cells in order to produce a very specific immune response, adding a layer of specificity to the response. The effector responses in case of the innate immune system are purely cell mediated. That is, only cells are responsible for causing for killing the pathogen or getting rid of the pathogen. Whereas in case of the adaptive immune system, it could be cell mediated and there could be antibody production. It's not very clear, but there could be antibody production. So, what are the cells involved in the innate immune system? Basically, these are cells that are involved only in recognition. An example of this is dendritic cells, but essentially all nucleated cells except for RBCs can function as cells that express innate immune receptors. So, the entire human body, as long as the cell is alive. And recognition and effector function is primarily by macrophages, to a lesser extent by your neutrophils, eosinophils, and NK cells. uh, See, NK cells and eosinophils are primarily effector, although they can recognize, they usually recognize better with the help of a macrophage. Okay, that is what I mean by that greater than. Then, in case of the adaptive immune system, the recognition is only by T cells and B cells. Now, this is with the help of a macrophage or a dendritic cell or any other cell which is able to process the molecular proteins of the antigen and express it on their surface. And we'll discuss the molecular details of that later. The recognition and effector function in a cell-mediated manner is only by CD8 plus T cells. In the non-cellular components, the main two non-cellular components of the innate immune system are the physical barriers that are there within the body, which obviously are the mucosal surfaces, the skin, etc., and the complement system within the serum and the extracellular fluid. And the main non-cellular components of the adaptive immune system are just antibodies. Now, there is a thing called immunological memory, as in once a host or a human has been exposed to a particular pathogen, they can remember, or their immune systems can remember that particular pathogen. Okay. So, classically, it is said that the innate immune system does not show memory, but that is not strictly true. And we'll talk about innate immune memory later. But yes, the innate immune responses do not have long-term memory, as in they are not long-standing. There's no long-standing memory because the molecular mechanisms by which it occurs often get overridden over time. Okay. Whereas adaptive immune responses are characterized by memory, and the basic unit of this memory is actually a cell, which can be very long lived as long as the life of the host or the human. So like, it can be as long as the person is alive. Okay. Now, all that is fine, but there are two clear problems that arise when you understand the overall functioning of the immune system. One is that obviously it is not one size fits all. So there are multiple types of pathogens, and therefore their diversity implies that the responses to each pathogen should be different. The other thing is that the human body is extremely compartmentalized. A pathogen could get into serum, it could then go into the intracellular compartments, it could get into, it could come out of the extracellular compartment, intracellular compartment back into the extracellular compartment. So it can play a game of hide and seek with the immune system if the immune system can only detect it in some places. Okay, so these are two problems that arise. Now, importantly, naturally, the whole compartmentalization issue is there with every multicellular eukaryote, but to some extent, but naturally, I'm talking about human beings here. Now, so we'll see how the immune system has evolved to tackle these constraints under which it functions. So the first constraint or the problem that the immune system has evolved against is pathogen diversity. Okay, so the constraint it puts is that the detection, processing, and response, that is each one of those circuits that we discussed, has to be specific for a particular type of pathogen. And what do I mean by type of pathogen? I mean this. This is the dendrogram of all of life. Uh, this is the Now, I've not shown viruses here because we don't really know whether viruses have arisen through, reductive evolution of a relatively more quote unquote advanced or derived organism. But viruses also would come here. Okay, but these are the general kingdoms into which the into life is different is divided. So among these, what is clinically relevant to us are some bacteria, some eukaryotes, and viruses. Okay, so which are these bacteria? That is this entire group. Okay, so the clearly a separate detection, processing, and response mechanism has to exist for bacteria. Similarly, a separate detection, processing, and response mechanism has to exist for viruses, and that also applies to fungi and to amoebae themselves, and to large multicellular organisms like parasitic worms. Okay, so as a result, uh, I'll discuss the immune system under these headings, and you'll understand that uh, there's a very clear separation between the mechanisms that respond to all of these separate types of organisms. So, uh, in a very broad overview, all immune responses therefore are not functionally identical. Uh, Yeah, so they mirror the heterogeneity of the biology of all possible pathogens. Okay, so what does that mean? So I divide immune responses into antiviral responses and non-viral responses, non-antiviral responses. Under non-antiviral, we've got antibacterial responses and antifungal responses. And again, bacteria can be intracellular, that is within a human cell, or it could be extracellular. So we have intracellular antibacterial responses and we have extracellular antibacterial responses. Now, viruses are obligate intracellular parasites but can circulate in serum. So there are extracellular circulating mechanisms to control viral infections, but no extracellular mechanisms as such. Okay. Now, how are viruses detected? Now, in the intracellular space, intracellular bacteria and viruses are detected in two compartments. So you've got a cell, you've got the extracellular space, you've got the intracellular space, and then the cell tends to internalize the external environment. So this kind of a vesicle that is internalized is called lysosome. So you've got the lysosome itself. So there are three separate compartments that are there. So in each one of these compartments we'll need a receptor, we'll need a response, we'll need an outcome. So there is the in case of antiviral and antibacterial responses, the intracellular compartments are lysosomal and cytoplasmic, and that is where the receptors are specifically located. Now, in case of extracellular antibacterial responses and fungi, because they're mostly extracellular, we have cell surface and intracellular lysosomal, because lysosomes are formed by internalization of the external environment. So that's where the mechanisms are located. And what is the kind of signaling that happens? I'm not going to describe the signaling right now, but broadly speaking, it can be called specific antiviral signaling. Okay, so the signaling molecules, the signaling cascade eventually results in an antiviral response. And we'll see that actually these signaling molecules downstream of everything other than for viruses, that is intracellular bacteria, extracellular bacteria, and fungi, are all very, very common and overlap because the effector mechanisms also overlap. Okay, and are effective in killing both. or all three types of organisms. So the outcome in case of antiviral responses is a immediate cessation of protein synthesis and nucleic acid replication within the cell that has detected the virus. So that is because the viruses have an Achilles heel, that is, they can only replicate within a actively dividing cell, or they need to use the host nucleic acid amplification and protein synthesis machinery to replicate. Uh, Obviously, bacteria and the other pathogens do not have this issue, so they need to be killed. Okay, so these are killed either using phagocytic cells like we just discussed, that is your neutrophils and macrophages, or the primary cell is killed, and we'll come to that. Okay, so I hope this much is clear. So again, it's quite clear that the detection, the signaling, and the response is highly specific and tailored to the particular type of pathogen. And there is some overlap in all antiviral responses, but there is the initiation mechanisms are slightly different, although they can all be killed essentially by similar mechanisms. Okay, now the second problem is the compartmentalization of the human body, is that which we just talked about also. So again, you need to have a separate detection, processing, and response system present in each compartment. So this has to be in the extracellular compartment, this has to be there in the intracellular compartment, it has to also be there within the lysosomes. Okay, so all three compartments have to be represented, have to have molecules that are able to detect the pathogen and are able to signal into the cell, and therefore are able to induce a proper response. So essentially, if I just take antiviral responses, they can be intracellular lysosomal, they could be intracellular cytoplasmic, they could be extracellular cell surface. So this is your cell, this is your lysosome within the cell, this is the cell surface. So there will be a receptor on the cell surface, there will be a receptor within the cytoplasm, different receptors, I'll draw it slightly differently, and there will be a receptor on the in the lysosome, all will be pointing inside. Okay, so there'll be three different receptors or the same receptor located at three different locations. The innate immune signaling response will be exactly the same, because regardless of whatever it is still a virus. So the response is to shut down protein synthesis. And we'll see even the molecular cascade that occurs is highly conserved between all three sites. The outcome is the immediate cessation of protein synthesis and nucleic acid proliferation. Okay, so yeah, so essentially the receptor location varies, but the subsequent signaling is very similar. So we'll be clubbing these together when we discuss it in our subsequent topics, functional topics on the immune system, and you'll understand how that makes it much easier to learn. Okay. Now I'll be discussing immunology under the following headings, and see, to be fair, I'm actually talking about clinically relevant immunology. But that does not mean I'm going to, avoid going into much detail. I will be going into as much detail as is necessary, and clinically, actually, a lot of detail is necessary. So I'll be going into the molecular details and functional aspects of everything. However, we'll be talking about the clinical relevance of that top point, and we'll be talking about the immune system as a dynamic system that changes from one phase to another phase, and will eventually build up to understanding it in that way, in a more kinetic way, in order to be able to understand how a disease evolves during its natural course within a host, that is within a patient. So again, the innate immune system and adaptive immune system, I'll be dividing them slightly because the topics are essentially non-overlapping. So I'll be taking this in five or six phases rather. And for the first phase, I'll be talking about one, pathogen detection and specific pathogen specific signaling in the innate immune system. Then in part two, I'll talk about cell to cell signaling. As we saw, the second circuit that we discussed was the first cell interacting with the second cell. So how that signaling occurs from the first cell to the second cell. Then we'll, uh, take a microscope and look at two specific types of cells, that is dendritic cells and macrophages, and thus have a clear understanding of the first circuit at least. Okay, the first two circuits at least. Then we'll add in the complement system, because no understanding of the innate immune system is complete without the complement system, that being the oldest essential form of the immune system. Then on the other hand, simultaneously actually, in the adaptive immune system discussions, I'll be talking first about T cell development and how adult mature T cells are formed. Then we'll talk about B cell development in both, and there are two phases to it: antigen dependent and independent, and we'll be talking about that. Then I'll talk about how T cells polarize in the context of a pathogen. So as you can see, the part one of the innate immune system and part three of the adaptive immune system actually complete each other. Okay, so while going through it, it's like a puzzle. All the pieces of the puzzle have to come together in order to get for you to get a deep, in-depth understanding of what's happening. Okay, and eventually we'll finish it off by understanding the molecular details of the immunoreceptor recombination. Once I'm done with phase one, essentially you will be quite clear about the basic functioning of the innate and adaptive immune systems, and how actually from there you can take it on yourself and understand everything clearly if you think about it. However, I will be going ahead and talking about in part 5 of the innate immune system, general regulatory mechanisms that are applicable to the innate immune system and by extension to the adaptive immune system. So there I'll be talking about how apoptosis regulates in immune responses. We'll talk about how immunoproteasome, that is a specific type of protein uh, machinery, degenerating machinery that is there within the cell, is very important in regulating immune responses. And then we'll talk about how TNF alpha signaling has got multiple ways in it which can signal, and it is context specific. And I'll come to that. Then we'll talk about some in part 5 in the adaptive immune system. We'll talk about some regulatory mechanisms specific to the adaptive immune system. Then in phase 3, we'll talk about part 6 in the innate immune system. We'll talk about innate immune lymphocytes, and I'll leave one entire discussion on the natural killer cells, very important in cancer biology and understanding immune responses to cancers and intracellular viral pathogens. Then we'll talk about innate lymphocytes, which seems like a little bit of a misnomer, but it's not very appropriate, and we'll see why. So we'll talk about lymphocytic cells, and mucosal associated invariant T cells. So also called mate cells. Then we'll talk about macrophage plasticity in immune responses, and in that way I'll talk about innate immune memory. What I just discussed, we'll be talking about. Then in part 6, we'll be talking about antibody structure and function. In traditional immune discussions on the immune system, this is often the first topic discussed. However, that is only because that is the sequence in which it was discovered. Okay, and in the present day and age in 2026, I don't think that that level of discussion is relevant anymore. You need to understand the immune system as a system because we understand it quite well now. Then we'll talk about organization of secondary and tertiary lymphoid organs, and I'll just come in our just immediately after this. I'll be uploading a series of talks on the structure of the immune system before we get into all of this. So you'll understand what are primary, secondary, and tertiary lymphoid organs. Then we'll talk about in part 8 of the adaptive immune system, immune responses at epithelial surfaces. So in this way, I'll cover the immune system quite deeply. Now in the fourth phase, and this will probably take me over a year, I'll talk about some other non-immune responses that are initiated by the innate immune system, like angiogenesis and the functioning of fibroblasts and extracellular matrix turnover. And you can see how this is developing into how continuing into discussions of individual disease pathogenesis. Then we'll get into human inborn errors of immunity, that is what we call primary immunodeficiencies. I'll talk about the main primary immunodeficiencies, their broad classification. In part 10, then I'll talk about how disorders of specifically adaptive and innate immune regulation result in lymphoproliferative primary immunodeficiencies and how they present. Then we'll talk about primary immunodeficiencies of the innate immune system, and we'll understand why I have first done the adaptive and then the innate. Then I'll finally close that chapter out by making a broad clinical diagnostic framework for primary immunodeficiencies. I'm not a pediatric rheumatologist, so this is the framework I use based on my assessment of primary immunodeficiency diseases deficiency patients, but I found it pretty useful clinically. Uh, Again, resorting to genetic testing in under all circumstances is definitely not warranted, and again requires a lot of technical expertise to interpret. So we'll get into that then. And finally, we'll try to understand the computational states that are used to model phase transitions. And this is best actually only studied in neuronal, mouse models of neuronal disease. So we'll understand the what kind of phase transitions occur, because again, as you have just seen, the adaptive immune system exists, or the innate immune and adaptive immune system exist in activated and inactivated states. And what determines that phase transition, what is the what switches on and off that switch, all of that makes a lot of, it's very relevant to how the disease presents, or disease of these systems present clinically. Okay, so we'll make an analogy of these phase transitions with immunological this thing. So I don't have any cellular data to corroborate this as of now, but you can see a lot of it clinically. And I'll try to, by that time probably I would have completed a significant amount of the systemic autoimmune rheumatic diseases, pathogenesis, and then it'll make more sense in a more whole sense. Okay, so that's my this is the format of how I'm going to approach the immune system. Now, before I finish off, I need to talk about some constraints that are posed on the immune system by natural selection that result in a difficulty in learning the immune system, particularly for somebody like me who finds it difficult to memorize things. Uh, so now, see, the thing is that this is how the how you would say the immune system has evolved. So initially there were innate immune responses that became derived immune responses, which are adaptive immune responses, and then we've developed complex interactions between T cells and B cells, and they result in immune interactions. So now the problem is that as you go through your our immune responses, uh, natural selection does not really weed out redundant mechanisms. So you could have three ways of doing something, and if they're equally valid and equally efficient, the process of natural selection is not going to remove that functional redundancy. So as a result, in the older, or quote unquote older, phylogenetically older parts of the immune system, you see a lot of functional redundancy. So you'll have multiple cell types functioning as cells that receive a signal, and you'll have multiple effector cells, as we just saw. Both dendritic cells and macrophages, and indeed every cell within the body can function as a receptor within the innate immune system. And the effector function can be by macrophages, it can be by neutrophils, it can be by eosinophils. So there is a little bit of functional, not very significant functional redundancy, making it a little confusing. Okay, and but however, once it comes to the adaptive immune responses, the functional redundancy is very minimal, and the different subtypes of T cells and B cells are very specific to very specific responses. So it makes things clearer, but it does create a large number of subtypes, and that needs to be dealt with. And I'll be dealing with them as I just discussed. So this is the general overview, the general schematic I'd used to explain patterns of inflammatory arthritis and how the immune system functions there. So as you can see, since this is the innate immune response, there is maximum phylogenetic redundancy there, and the adaptive immune responses have minimum phylogenetic redundancy. Okay. Uh, okay. Now, why do I care? Why do I care as a clinician? See, it's not just because I specialize in clinical immunology and rheumatology. It's also because it is fundamental to understanding essentially every type of pathogenic mechanism that occurs in the human body, maybe with the exception of purely degenerative disorders. Although we could probably there that is not true even. Okay, so yeah, its immune responses still constitute part of the pathogenesis of degenerative disorders. Now, however, there are four parts in addition to primary immunodeficiencies. There are three. Okay, so with primary immunodeficiencies, there are another three part clinical scenarios in which mechanistic understanding of how immune responses occur becomes very relevant. The first is infectious disease. Now, see, the clinical presentation of infection diseases reflects the pathogen interactions with the human immune system. So, most commonly in an immunocompetent host, the way a pathogen enters the host is it attaches to an epithelial surface causes local innate immune activation that results in some macrophages and neutrophils coming in, and that temporarily the organism is able to evade detection and the response, but eventually the innate immune system catches up. But in that process there is tissue damage, and that damage allows for some nutrients and to be available to the organism, which then proliferates using those nutrients and then moves on to the next person or the next host. Okay, so these result in very classical clinical syndromes. These are the most common infectious syndromes that we come across. That is your community acquired pneumonia in the respiratory tract, your acute diarrhea or Clostridium difficile infection in the gastrointestinal tract, your urinary tract infection, that is cystitis, pyelonephritis, and prostatitis in the urinary tract, and skin and soft tissue infection in the skin and soft tissue, as the name would suggest. So these are best studied during evaluation of that symptom. That is why I will be discussing community acquired pneumonia in an approach to acute dyspnea. And similarly, I'll be discussing I've already discussed the pyelonephritis as a urinary tract infection in cases of abdominal pain or focal abdominal pain with vomiting. Okay, so similarly, I'll be talking about skin and soft tissue infection in case of infections of the skin or approach to rash and cellulitis. So these are best approached in a organ system way. Okay, because the main clinical symptoms are related to the site at which the infection is occurring, although the infection follows the same three phases: attachment, local innate immune evasion, and then moving on to the next host. Then there are some organisms that modulate immune responses in order to get away with things and to be able to cause more severe infections. So an example of this is by activating innate immune receptors that are actually inhibitory. So remember the detection part of the innate immune response. That detection of the pathogen stimulus that can induce these cells also to get inhibited. Okay, now why such receptors exist that inhibit the subsequent response is because we don't want the innate immune system to be overactive, but pathogens have obviously been selected to take advantage of this slight chink in the armor of the innate immune system. So an example of this is pathogens such as mycobacteria or HIV and HCV viruses attaching to a receptor on macrophages and dendritic cells known as DC sign, which is a C-type lectin receptor, and inducing subsequent inhibitory responses rather than activation of the immune system. Okay, the other very common mechanism that is used, actually these are the only two mechanisms that are used, is inhibition of fusion between phagosome and lysosome. So essentially all innate immune effector mechanisms require the effector cell, that is a macrophage or the neutrophil, to engulf the cell, that is phagocytose the pathogen, and then fuse that pathogen containing vesicle with another this thing vesicle called the lysosome, as we've just discussed, and that phagolysosome then digests the kills and digests the organism. So if you prevent this fusion, okay, or somehow the pathogen manages to survive within the phagolysosome, uh, you end up getting the pathogen essentially is able to avoid being detected and killed off by the innate immune system, and then adaptive immune system responses take time to happen, and then the organism has a way out. Okay, so this is the prototype of this kind of a response is activation of inhibitory innate immune receptors, is like as I just discussed, mycobacteria, also Trophilima virpili, actinomycosis, and nocardial infections. Now inhibition of phagosome and lysosome fusion, the master of the art is actually enteric fever, that is typhoid, and uh, Q fever. Okay, and to some extent melioidosis also. We'll see melioidosis also has a ability to move from one cell to another actively. Okay, now both these mechanisms are there in case of brucellosis, and actually clinically brucellosis can at times look like mycobacterial infections and at times can look like enteric fever. So that's why that happens. Okay, now the third thing that can happen is that the organism can get into parts of the body or within compartments of the body where it is now not it cannot be detected by the immune system. Now I just said that the immune system is distributed in all compartments: extracellular, intracellular, cytoplasmic, intracellular, lysosomal. But extracellular, within the serum, it is detected by the complement system. So if a organism is able to inhibit the complement system by some mechanism, it is able to circulate freely in serum, and that mechanism is called serum resistance. And organisms that then utilize this are Leptospira, all the leptospira actually, the spirochetes, that is leptospirosis, relapsing fever, Lyme's disease, and syphilis. The second thing that can happen is an organism can get into a particular cell, that is, it can go into an intracellular niche compartment and then move from one cell to another. Okay, so this could be an endothelial infection, or it could be a intraepithelial infection, for example. So epithelial infection and then movement from one epithelial cell to the next cell is done by listeriosis, to also done by melioidosis. So Burkholderia pseudomallei also does this, but it does this between macrophages, and we'll come to that later. And endothelial, getting inside endothelial cells is done by rickettsia among bacteria. Okay, but see, I'm only talking about bacterial infections here. Okay, it is also done by dengue virus and other arboviruses, and therefore dengue hemorrhagic fever and rickettsial infections can clinically be essentially impossible to differentiate. Okay. Then we have intra-RBC infection. So this is done by one bacteria, that is Bartonella. Okay, and that has some clinical implications which we'll come to later. Okay, this is also done by a parasite, which is convergently evolved this ability to to parasitize RBCs. Now, why parasitize RBCs? Because RBCs are the only non-nucleated cells within the human body, and therefore they are not able to process intracellular pathogens and show them to surrounding immune cells. Okay, so it forms a immune privileged site within the immune system, which where the pathogen is not going to be detected. So I like to classify infectious diseases into these three buckets, because the clinical presentations are limited in each case as long as the patient is immunocompetent. Once the patient is immunocompromised, the situation changes quite significantly. We'll talk about that later. Okay. So these are the infections that, from a clinical diagnostic standpoint, are the most interesting, and they form differential diagnosis of systemic autoimmune rheumatic diseases and hematological malignancies and other multisystem disorders. Okay, then we have hematological malignancies. Now, see, the hematological malignancies arise from cells that constitute the immune system. So these malignancies can mimic immune activation by a infective host, that is by a pathogen. So even though there is no pathogen there, the immune response, there can be an aberrant immune response. An example of this would be the Pell-Epstein fever that is described in Hodgkin's lymphoma. Okay, so fever is a response, and that response is occurring not because of a pathogen, but because there are neoplastic immune cells which are doing aberrant immune responses. Then it can mimic immune activation by an autoimmune or autoinflammatory disease. That is some of the systemic autoimmune rheumatic diseases I deal with. So you can have warm antibody type autoimmune hemolytic anemia and mature B cell malignancy called chronic lymphocytic leukemia, for an example. Now, they also have very characteristic, tissue involvement, and this is because certain cells within the adaptive immune system, particularly, tend to localize within certain tissues. So, an example of this is subtypes of T cells. So, mature T cell malignancies present only in one of three ways. That is, they could have primary cutaneous involvement. There could be circulating neoplastic cells. That is, there could be a leukemia, or there could be a generalized lymphadenopathy. And this generalized lymphadenopathy often coincides with the aforementioned features of aberrant immune activation. So an example of this, a classic example of this, is a nodular follicular T cell lymphoma, angioimmunoblastic, which was previously called a angioimmunoblastic T cell lymphoma, and this can closely mimic a patient with SLE, for example. Okay. Now, the last is one of four ways. Sorry, four ways. That is the intestinal tract. Okay, and we'll discuss why and how, and it'll become apparent as we go into the details of how the immune system works. Now, finally, obviously, and our deep understanding of the immune system allows us to understand the pathogenesis of systemic autoimmune rheumatic diseases. Rheumatic in quote unquote, because I don't really understand why they're called rheumatic diseases. Uh, so, systemic autoimmune diseases. And this is how I explained how systemic autoimmune rheumatic diseases arise from complex interactions between the functional components of the immune system. So this was in our discussion on an approach to logical approach to framework for a logical approach to both arthritis and then to rash. So there could be innate immune activation that is occurring primarily, or due to a failure of adaptive immune responses, because adaptive immune responses eventually inhibit the innate immune system. So we discussed axial SPA and peripheral SPA as examples of this, and Behçet's disease also as an example of this. Then the second thing could be an adaptive immune response due to an actual autoimmune response, that is against a very specific antigen, and that we discussed is particularly the prototype of that is seropositive rheumatoid arthritis. Although seronegative rheumatoid arthritis, some cases fall along that side, some cases fall more on the first side, more towards this side. Okay. Then finally, we discussed that there are situations in which the adaptive immune system aberrantly activates the innate immune system, and that the prototypes of that are the polygenic alpha interferonopathies like SLE, antiphospholipid antibody syndrome, systemic sclerosis, primary Sjogren's disease, dermatomyositis, antisynthetase syndrome, and ANCA vasculitis. Okay, so this is how we logically understand what are the patterns of arthritis that occur clinically. And this is also how I have used the framework I've used to logically understand the patterns of rash that we find clinically. However, in both of these series, I cannot move forward without a deeper gaining a deeper understanding of how the immune system functions. So that is why it became imperative for me to cover the immune system separately here. Okay, so uh, this is what I had planned. Now, in addition to that, in addition to go through the immune system this year, I'll also try to draw parallels between. Initially, I'll try to draw parallels between the stages of T cell and B cell development and how the pathogenesis of immunological or hematological malignancies. Okay, and we'll then extrapolate this in those discussions to understand the clinical features that might occur. Okay, then we'll understand infectious disease from a mechanistic standpoint, an overview of which I've already gone over in this discussion, and this allow us to predict, depending on the clinical presentation, whether or not an infection is a likely differential in a particular case. Okay, and that becomes surprisingly useful in cases where cases where you're suspecting an infection by more immunomodulation, or we suspect an infection by evasion of the immune system used by occupation of a immune privileged niche. That is either serum resistance or getting into endothelial or slash epithelial cells and then moving from one cell to another, or the third mechanism that is becoming intracellular within an RBC. Finally, we'll try to understand this pathogenesis of systemic autoimmune rheumatic diseases, and this will require a mechanistic, dynamic understanding of phase changes within the immune system. Uh, which Okay, this is something that there's a forward and backward feedback loops are there. So the better you understand the immune system's physiology and functional dynamics, the better you understand the pathogenesis of these disorders, and vice versa. Okay, so it has to form a coherent whole in your brain to be used relevant in a clinical setting. So we'll talk about polygenic alpha interferonopathies like SLE, antiphospholipid antibody syndrome, primary Sjogren's, dermatomyositis, systemic sclerosis spectrum, and ANCA vasculitis. Then we'll talk about excessive disorders with excessive Th1 and Th17 polarization, which essentially, but not autoimmune disorders, that is sarcoidosis and giant cell arthritis. Then we'll talk about the true systemic autoimmune disorders. So these are autoimmune, as in there's an immune response against a self antigen. Okay, with excess Th1 and Th17 polarization. So that would be RA and granulomatosis with polyangiitis. Then we'll talk about disorders in which there is just a excessive innate immune activation. So that would be your classic autoinflammatory disorders like Still's disease, and two disorders that are usually classified as vasculitides because they primarily affect vessels, that is Behçet's and Takayasu. But also, I don't like to classify them along with ANCA vasculitis and things like that because the clinical presentations are so different. Okay, so that is just a fallacy of the way the clinical approach to this disorder has evolved. So I don't like to follow that because it's clinically not very relevant. Then we'll talk about disorders of immune resolution, and the prototype of this disorder is IgG4 related disease and the entire spectrum of that disorder. And finally, we'll end the discussions on the systemic autoimmune rheumatic diseases with disorders with excess Th2 polarization, that is essentially allergic disorders. That will include asthma, histaminergic urticaria, and atopic dermatitis, etc. So that brings me to the end of this. It's relatively concise overview of the functional overview of the innate immune system, both innate and adaptive. And I'll be uploading subsequently. I'll be uploading relatively short videos on the individual structural components of the immune system. Then we'll jump into the topics that I have just enumerated in this particular talk. So I look forward to seeing you then. Thank you for watching, and take care.